Evaluation of acidic fluid. Grading of ascites. Grade 1 is detectable only by careful examination. Grade 2 is easily detectable, but of relatively small volume. Grade 3 is obvious ascites but not tense. Grade 4 is tense ascites. With the patient in supine position, hands by the side of the body, and legs flexed, at the knee joint, percussion of the abdomen reveals dullness if fluid is present within the cavity. Regional percussion at each of these areas is done. In supine position, acidic fluid, if present, settles in the flanks, causing a dull percussion in the lumbar regions. Fluid thrill. Procedure. The patient lies supine. Place one hand over the lumbar region of one side, get the patient to put his hand firmly in the midline of the abdomen, as shown in the image, then tap gently at the lumbar region. In ascites, a thrill or wave is felt by the detecting hand at the opposite lumbar region. The patient's hand is kept at the midline to dampen impulses that are transmitted through the abdominal fat. Greater than 2,000 milliliters of fluid must be present to elicit this sign. Shifting dullness. Procedure. With the patient lying supine, percuss laterally from the midline until dullness is detected. In normal individuals, flanks are resonant. In moderate ascites, the flanks are dull. On shifting the patient to one side, the fluid shifts from the flanks, and the flanks empty, resulting in a resonant note. 1,000 milliliters of fluid should be present to elicit this sign. Puddle sign. This can be elicited by percussion or by auscultopercussion. Patient lies in the prone position for 5 minutes, and then goes on all four limbs, so that the middle portion of the abdomen is dependent and the back is horizontal. Now percuss around the umbilicus and elicit dullness. If acidic fluid is present, previously resonant area becomes dull. To auscultate, place a stethoscope over the umbilical region and tap the abdominal wall from the periphery towards the umbilicus. A change in the quality of sound is perceived while crossing the fluid column. A false positive result is seen in massive splenomegaly and distended bladder. It can detect 120 milliliters of acidic fluid. Acidic fluid should be analyzed for the following parameters: gross appearance, specific gravity, protein or albumin content, and differential cell count. The following features are looked for on gross appearance. It appears clear. In uncomplicated ascites, a translucent yellow color may be seen, with cirrhosis. It appears turbid, if spontaneously infected. Milky colous ascites seen in cirrhosis, abdominal malignancy, and lymphatic abnormalities. Pinkish or reddish, bloody appearance, is seen with trauma or malignancy. A brown color is seen with deeply jaundiced patients. It may also be seen in a ruptured gallbladder or perforated duodenum. The specific gravity remains less than 1.016 for congestive cardiac failure, cirrhosis of the liver, and nephrosis. It is more than 1.016 in neoplasms, pyogenic peritonitis, and pancreatic pseudocysts. Protein content. Serum albumin, acidic fluid albumin gradient, also known as SAAG, helps to determine the cause of ascites based on the protein content in the fluid. SAAG of more than 1.1, that is high gradient, suggests that the ascites is due to portal hypertension. Differential cell count. If the fluid is an exudate and contains greater than 250 WBCs per milliliter, it suggests tumor or infection. To get more such high-yield medical content, don't forget to subscribe. BasidiaMED. The easiest and fastest way to take advanced clinical history.